We're really delighted to welcome you to this webinar today. We're really excited about the report and to share all the things that we learned in it with you. And hopefully this event can be a really useful way to kick off making the better and more inclusive services for trans people in Scotland. I just want to do a little bit of housekeeping for everybody. Just to let you know that the webinar is being video recorded. Now, of course, none of your cameras are on, but later on in the session, there'll be a chance for you to ask questions to all of the panelists, and there'll be two options on how to do that. You can do it anonymously or with your username. As I say, there is a video recording happening and that will be put up on YouTube after. So if you don't want your name to be shared, you should ask your question anonymously. Similarly as well, if you think of a question at any time, you can submit it at any time, but we won't be doing the Q&A until a little bit later on in the session, after we've heard from some of the researchers about the findings and gone to our guest speakers to kind of have some first reflections on the research. Also, we know that we've got a range of attendees today. We'll have trans community members, we'll have people working in sexual health services, people from various other sectors. And so we know that there'll be people with different levels of knowledge and understanding of trans people, language, our lives. We want this to be a really kind of useful, constructive learning space to hear about the research, to think about next steps forward, but also for it to be a learning space. So please do feel free to ask questions and don't feel like you can't ask them because you're a little bit unsure about how to ask them exactly. We're really, really happy to answer everything we can and to make this as useful as possible. But obviously as well, please do kind of be as thoughtful and respectful as you can be in your kind of choice of the way you choose to ask questions or share any of your thoughts and feelings about things. Just to let you know how the event will run. First of all, we'll hear from Oliver Wayne and Ruth McKenna about the research report and findings. And then after that, we'll go to our guest speakers to ask them some questions as a panel. And that will be Meg John Barker, Gina Roche, and Michelle Ross. And they'll all introduce themselves at the kind of points at which we're doing those various bits of the event. Rather than me kind of speaking for ages, trying to talk about them, they'll be able to tell you about who they are and why they're here. If at any point you do have any technical difficulties, you can send a message to Jen Goff and hopefully she'll be able to help you with those. And also the Waverley Care account will be tweeting about the event throughout, and they'll be using the hashtag care throughout. So if you do want to live tweet about the event, you'll be able to use that hashtag to see what people are saying and to get involved in the conversation. I think that's probably about enough from me to start with. So what I'll do is I will hand over to Oliver and Ruth to tell you all more about the report and its findings.
Hi folks, I think we're going to get a presentation up shortly. That's I'm Oliver Wayne, my pronouns are he and him. I'm one of the peer engagement officers at Waverley Care and have been involved in various other things to do with trans healthcare and sexual healthcare, including the Chalmers GIC film project, and one of the committee members for Transmasculine Scotland. And I've written about HIV in Disclosures, the book with HIV Scotland. So this presentation is going to be a short presentation about our research project exploring trans and non-binary people's access to sexual health services in Scotland. We're going to give you a bit of a background of the research and why we felt it was needed to do it, how we conducted the research, what we did, what we found, and what we recommend as a result of these findings. So yeah, on to the next slide, please. So a bit about why we felt the research was needed. This was a joint project between Waverley Care and Scottish Trans Alliance. Waverley Care is a HIV and Hep C and sexual health charity supporting people across Scotland by working to reduce new infections, increase testing, and provide support and challenge stigma and discrimination facing those with HIV or Hep C. Scottish Trans Alliance are a charity working for gender identity and gender reassignment equality and human rights in Scotland, specifically to improve the lives of trans and non-binary people. After a number of discussions in kind of late 2018, early 2019 between Waverley Care and Scottish Trans Alliance, there was a recognition, mutual recognition of the need for research into sexual health and well-being of trans and non-binary populations, specifically in Scotland. HIV and sex work seem to be covered quite a lot in literature, but not general sexual health service access. We know that trans women are more likely to be HIV positive, and other papers have suggested the same prevalence in trans men. As you can see already, non-binary people aren't included in these statistics, and we couldn't find any research relating to non-binary people's HIV prevalence. As with many marginalised and oppressed groups, there are extra barriers to trans people engaging in sexual health services, such as discrimination, a lack of trans competent care, and fear or actual negative experiences in sexual health services. We know trans people are more likely to be vulnerable in other ways, such as high alcohol and drug use, or poor mental health, intimate partner violence, domestic abuse, and these things also create barriers to accessing services. On to the next slide. So a bit about what we did. We asked the question, what are the barriers and facilitators to trans people accessing sexual health services in Scotland? And we commenced a peer-led project with 2 paid trans researchers, myself and Oceana Maud, who unfortunately couldn't be here today. We both led focus groups and interviews to build rapport between trans participants and having trans researchers. And there's kind of a mutual trust already, and a way of speaking about trans healthcare that we share. It was managed and led by one cis researcher, Ruth, and there was some input from cis researchers at the coding and transcription levels as well. We also did a survey, which ended up being the most well-responded survey of trans health in Scotland, with 289 participants responding after data cleaning. We conducted focus groups and interviews, and in the funding accounted for paying trans participants for their time and travel expenses, knowing that financial barriers can really impact the people who would even take part in the survey and research at all. And given it's already an adversely impacted community who can experience poverty at higher levels, we just felt that this was appropriate. We also provided food and refreshments for 2-hour focus groups, just to make it more accessible for people. Other ways we made it accessible was to provide written and spoken elements to the groups. So there was parts where we could, people would draw or doodle about their ideal sexual health service. We also had at some points dictation, and facilitators would be writing notes on post-it notes to kind of promote discussion. And later, some of the interviews were with participants from the groups, just to allow more private space to discuss things that might be more intimate details or more personal topics. We also interviewed 8 sexual health practitioners to understand better their views on delivering sexual health care to trans patients, and a bit more about what barriers or facilitators to providing good care might be in terms of a practitioner perspective. And I'll hand over to Ruth for some of the findings.
Hi everyone, my name is Ruth McKenna and I'm the Senior Research and Communications Manager at Waverley Care, and I was one of the researchers on this project alongside Oliver and Oceana, who can't be here with us today. So I'm going to briefly take you through some of our findings and then move on to our recommendations. So firstly, to talk a bit about the survey findings, as Oliver mentioned, we had 289 respondents. 60% of respondents were based in the Central Belt, which broadly reflects the kind of population distribution of Scotland. It was a largely young sample. 3/4 of people who responded were aged between 18 to 34. And we had a reasonably good gender balance, although I should say that trans women were underrepresented in the survey and also in our focus groups. So that's a limitation of the research that's worth highlighting. In terms of people's experiences of visiting sexual health services, 40% of respondents had visited services in the last 2 years. Positively, in general terms, 60% reported positive experiences, although in the report we talk about some of the different experiences reported by trans men, trans women and non-binary people, and there were different areas kind of reported in terms of where there might be room for improvement for each of those population groups. One of the areas that came out of the survey that was particularly important around improvement, especially for non-binary people, was around access to pre-exposure prophylaxis, or PrEP. So for anyone who doesn't know, PrEP is a medication that you can take if you're HIV negative, and it will prevent you from contracting HIV through sex. In Scotland, PrEP is available on the NHS if you meet an eligibility criteria, but that eligibility criteria is articulated with reference to gender, and so that made it quite challenging for some of our non-binary participants to kind of interpret whether their identity and the kind of sex they were having meant that they would be eligible to access PrEP. So that's one of the really key areas that came out of the survey in terms of looking at ways to improve how PrEP is marketed to trans and non-binary people. In terms of our qualitative findings, so we used an adapted and kind of simplified socio-ecological model to understand some of the barriers and facilitators that our participants faced when accessing sexual health care. So that essentially means looking at all the different levels of a person's life and the different ways in which factors might interact or affect how they engaged with services. So we looked at people's individual experiences, at the kind of social and community dimension of people's lives, at the organisational dimension. So for most participants that was specifically the NHS, but also included third sector organisations that deliver sexual health services in Scotland, and finally at the policy dimension. So, I mean, the report's launched today, so we'll not talk in too much depth about the findings, but just to give a bit of an overview. At the individual level, obviously one of the key barriers for people engaging with services was fear, and for some of our participants that was fear based on past negative experiences that then put them off engaging with services in the future, while for others was more about a perception of how they would be treated, and for some that was to do with experiences of engaging with general healthcare services and gender identity services, which in turn meant that people were less likely to engage with sexual health services. The individual's ability or access to the right information to assess levels of risk was also a factor. So that's something I mentioned in relation to PrEP specifically, but essentially whether someone was able to access information that helped them to understand whether they were at risk of contracting HIV or other STIs, and therefore could make a decision about when was right to engage with services. At the social community level, people talked about the importance of support from family and friends, both in terms of encouragement to access sexual health services, but also in supporting them to attend appointments. We did have kind of inconsistent experiences reported as to whether people were allowed a partner or friend to accompany them to intimate examinations. So we talk a bit about that in the report and refer to the relevant General Medical Council guidance, which does say that somebody should be allowed a friend or partner into an intimate examination. And that's one of our key recommendations. In terms of the community dimension, people really valued information generated from within the trans community, and because of the lack of officially generated information from within the NHS and other services about trans sexual health, what we found was that many of our participants sought information from within the community, and that was a really important and valued source of information. People did have some reservations about validating information they received from community sources, because there was some uncertainty as to whether the person giving the information was necessarily qualified to deliver it. And so for many of our participants, the solution to that was for trans people to play a more active role in NHS and other sexual health service delivery, so that people could both benefit from having trans people giving information, being in similar situations, but at the same time there was some level of validity and robustness to the information that people were receiving about sexual health. There's a lot in the report in terms of organisational barriers and facilitators. Some of the main ones were around accessibility and inclusivity. So there were general points made about the accessibility of services, things like stairs and services, lack of access to lifts, which are obviously barriers that are relevant to the general population, but when there are additional barriers that someone may experience because they're trans or non-binary, then that can, I suppose, present an additional challenge in terms of someone being able to engage with the service. People talked about the very gendered environment of sexual health clinics. So often there would be, there weren't gender neutral toilets available. Leaflets about different sexual health topics were communicated with reference to gender rather than anatomy. So information about smear tests would be targeted at women, and things like that, which made it difficult for people to necessarily understand whether information was or wasn't relevant to them and their circumstances. Participants talked a lot about data sharing, so this is something quite specific to the makeup of sexual health services and gender identity services in Scotland. The main gender identity clinics in Scotland are based within sexual health services and use the same clinical record monitoring system. So that means that a person who's accessed a gender identity service, their electronic record of having done that is visible to people in wider sexual health services and vice versa. Whereas sexual health information isn't viewable to the wider health service. So people talked about that as a barrier because they didn't always want that information to be shared across both services or didn't realise that that was the case. So one of the things we talk about in the report is the need for there to be more transparency about, you know, the way in which the GICs are located within sexual health services and what that means in terms of access to information across both services. Participants talked about practitioner level of knowledge and training, both around trans identities, but also specifically around trans sexual health needs. So some specific topics that came up were around PrEP dosing for trans men and a need for more specific information around that. A lot of the people we talked to felt that they had to educate themselves before they went to a sexual health clinic appointment, rather than it being an experience where they would necessarily learn something about sexual health. And that was a real barrier to engagement. I've mentioned, I've kind of talked about information provision already. That just kind of relates to the way in which information was communicated, and that primarily being in gendered rather than anatomical terms. Whereas when risk factors or sexual health information was communicated with reference to anatomy and body parts and types of sex, then people found it much easier to understand what was and wasn't relevant to them. In terms of the policy environment, one of the key barriers people talked about was transphobia and some of the public media political narratives around reform of the Gender Recognition Act. People talked about that not necessarily as a kind of immediate everyday barrier to engagement with services, but something that was in the back of their mind and made it more difficult to engage with any public services, but particularly sexual health services where you know, I suppose it's a very intimate and exposed environment, and there's some good quotes around that in the report. Some participants also talked briefly about austerity and the kind of structural environment within which health services operated, so acknowledging things like waiting times, which again apply to everyone trying to access sexual health services, but when you've already got another layer of barriers there, it's a kind of extra barrier to engagement. In terms of our interviews with sexual health practitioners, most of the practitioners we spoke to recognised that you know, they weren't necessarily experts in trans sexual health, and everyone we spoke to wanted to learn more and genuinely wanted to deliver good care to the people they engaged with. There was a desire across everyone we spoke to be able to access further training and have the time and capacity to do that. Practitioners also talked about wanting guidance around how to ask about pronouns, how to ask about people's sexual partners or sexual behaviour in a trans inclusive way. So by and large across our practitioner interviews there was an acknowledgement of some of the limitations in knowledge and a real desire to remedy that with training and guidance. In terms of our recommendations off the back of these findings, I've essentially copied these into the slides, but I'll not read them all out in full, but I'll just give a kind of overview of each of them. So in terms of our policy level recommendations, there's recommendations relating to how trans people are prioritised and talked about in the next sexual health and bloodborne virus policy framework, and the funding that's associated with that framework. We've also got a recommendation around bringing forward reform of the Gender Recognition Act, and finally a recommendation around showing leadership on upholding existing rights in relation to equality, inclusion and human rights. For NHS sexual health services, We've kind of split our recommendations into service design and training and staffing needs. So I'll just go back to service design. So these relate to things around how gender is talked about and communicated within services, in waiting rooms and toilets, making public commitments to equality and publicising complaints and feedback, making sure that information is communicated with reference to anatomy rather than gender, and maintaining transparency about the option to access services using a pseudonym. And that specifically relates to the issue I mentioned around information being viewable across different services. And so one solution to that is that people do have the option to access services using a false name, which means that those different electronic records can't be linked. In terms of training and staffing needs, we've got several recommendations around making sure that staff have access to relevant training, both about trans identities, but also around specific sexual health information as it relates to trans people. Working with trans advocacy organisations to ensure that training is delivered. Looking at employment options for trans people in clinical or non-clinical roles, and also looking at options for wider training around needs of sex workers, neurodiversity and trauma-informed care. In terms of clinical guidance, so much of this corresponds with BASH, the British Association of Sexual Health and HIV, recommendations for integrated sexual health for trans, including non-binary people. So this is things like asking for names and pronouns as part of a routine inquiry, not making assumptions about a person's gender and sexual activity, transparency around the use of shared electronic recording, making sure that clinicians are familiar with that BASH guidance, and making sure that clinicians are familiar with general medical council guidance around intimate examinations. And that relates to what I said earlier about partners being allowed into appointments. Also some recommendations for third sector sexual health and bloodborne virus organisations, so that would include Waverley Care and other similar organisations. So looking at ways that Waverley Care and other organisations in the sector can seek funding for and produce bespoke sexual health information on key topics like PrEP and HIV prevention, work in partnership with trans advocacy organisations to deliver bloodborne virus and STI testing, as well as to potentially deliver sexual health information services, sessions within sexual health services. Look at opportunities to provide community-based models of sexual health care to trans people, as is currently the case for other communities who are disproportionately affected by HIV, and in general to ensure that all sexual health information resources that organisations produce are trans inclusive. Finally, recommendations for trans advocacy organisations, so that would include Scottish Trans Alliance and other similar organisations. Again, to look at options for funding to deliver training to sexual health practitioners on delivering trans-inclusive services, working in partnership with sexual health and BBV organisations to provide advocacy to trans people accessing sexual health services, and to look at options to deliver information sessions both for trans people and for practitioners around sexual health needs and service needs. There are more recommendations in the full report, but that's kind of overview of what we're recommending to various different stakeholders. Just to wrap up, so thank you for listening to myself and Oliver. We'll be very happy to answer questions about the research in the Q&A. You can do that anonymously or using your name in the Q&A box. I've popped our contact information up at the bottom there, but we're very contactable if anyone has questions after the event, so do feel free to get in touch. And I'll just pass back over to our chair.
Great, thanks very much for that, Oliver and Ruth. Yeah, it's an amazing report. There's so much info in it, and I'm really excited about the kind of concrete steps and recommendations that it lays out. But we're now going to go over to our guest speakers and panelists. So first of all, I guess essentially the first question is to kind of hear what your kind of initial reflections, thoughts, take are on the report, its findings, its recommendations. I'm going to ask each of you, as I said at the start, just to let everybody know kind of who you are, kind of your area of expertise around sexual health. And I'll go to Michelle Ross first, please, if you want to say hello and kind of give us your first thoughts and reflections.
Thank you. Hi there. can I just say, first of all, congratulations on a fantastic, well done, ethically well done report. I'm really excited about it. So the work that's gone into it is fantastic. And a lot of the findings are why Clinic Q came about. So I'm Michelle Ross, I'm the founder of Clinic Q, as well as I'm a psychotherapist. I've been involved in HIV and sexual health delivery of services for 32 years. And Clinic Q has been delivering services now for 9 years. Well, nearly 9 years, coming up to 9 years. It's our 9th anniversary soon. And so what was shining out of this is about trust as well for me. So when Clinic Q started, we, for the first few months, no one came. Well, why should they? We're trans, we let people know we're trans, but, you know, why should they didn't have trust in sexual health services, most people, because there'd never been anything like it before. So why should they come to us? So we set about inviting people for a familiarisation session. Have a look at us, see who we are, look what the rooms are like, look what we do, look at our forms, give us feedback there and then if you want, you know, straight away, to look at ways we can develop. Because although we're trans, Clinic Q is a trans organisation, so clearly we're trans-led, but we are inclusive people who self-identify as cisgender. So, you know, we are inclusive of many genders within our services that deliver our services. And we have 11 therapists. But just to come back to that familiarisation session, also, we went out to people. And I think that's what you've done, really. You've gone out to people with this to see what the communities want and what clinicians know and what clinicians don't know and how they can improve. So I think this report is really extensive. And I think it's great for Scotland, but it's also great for many other countries globally, I think, yeah. And so I'm really pleased about this finding. Did you want me to say more? Because I can go on. So, okay, so I guess I'm going to be asked more questions later, and maybe others want to speak in a moment. I'll just hold that there for now. Well done.
No, great. Yeah, it's great to hear that you're so enthusiastic about it. As yeah, really excited about it myself too. So that's awesome to hear. I will next hand over to MJ Barker to tell us a little bit about their self and give us their first kind of thoughts, reflections on it all.
Thanks so much, Vic. So yeah, I'm Meg John Barker, or MJ for short, and my interest in this area is that I've written about gender and sex, well, gender, sex and relationship diversity for years. So I'm primarily a writer. So books you might know of is I write this sort of comic series about this queer graphic history and gender graphic guide. And we've got sexuality, a graphic guide coming out early next year. But I also write self-help type materials about gender and sexuality. And I do a podcast as well that covers those topics. So my background's in psychotherapy and in academic research, but I'm lucky now that I get to be a writer full time, and it's that sort of materials. So I'm really interested in these questions around gender and sexuality, and the question of how we can improve sex for trans people, for everybody, but specifically for trans people. I was actually up in Scotland a couple of years back and did a really fun workshop around trans and sex that I might be touching on in answer to some of these other questions. And I should shout out as well we've got Clinic T down here in Brighton, where I live, which is kind of followed on from Clinic Q. So there's some really good kind of trans-specific sexual health services around. But I loved the document. I loved the report. I think it was a really great piece of research. It's going to be so helpful to have that evidence base to kind of refer to from now on. I really like the depth and the breadth of it. You know, the fact that you had this breadth of so many people responding, but also got to go in depth with those interviews, and that you included the sexual health professionals. I really loved the socio-ecological approach. I hadn't heard it called that before, but it feels so important and so rare to situate the individual person, the client or the patient, in their relationships, in the organisation, in the social environment, in the wider culture. You know, you brought in the current sort of levels of transphobia and the impact that's having, as well as the impact of policy. And I think that's just a really great way of understanding people and how they're, how there's the blocks to access, or the things that open up access on each of those levels, and how we have to be mindful of those multiple levels at all times. They impact everything about us, those multiple levels, and it's so easy in research and in therapy for people to get very individualized and only look at their like individual fears or individual access. And it was just great to see that much more social nested approach. The things I'd like to pick up on as we go through would be some stuff around consent informed approaches, trauma informed approaches, maybe pick up on some of the non-binary stuff because that's a particular area for me, and really thinking about, I think Juno may be interested in this as well, this sort of idea of maybe going a bit beyond sexual health, as in sort of preventing and treating STIs and that kind of thing, to thinking about sort of sexuality more broadly and how we can encourage like really good sexual experience and how that links to these issues around consent and trauma as well as around health. So hopefully we can kind of get into that as we go on with the discussion.
Great, thank you very much. And last but not least, I'll ask Gina Roche to introduce themselves and again just to give us some of their first kind of reflections and takeaway from what they found from the report.
Okay. My name is Juno Roche and I'm a writer. And it's a really weird thing. Whenever I do these events, I always think that I'm going to be detached. Like I always think I'm going to read a report and that I'm going to be detached and that I'm going to be able to speak like other people. And as other people speak, there's this voice in my head that says, but this report is about me. You know, this report is about me. This report is about my life. I have lived with HIV. I was diagnosed before there were any medications. I was given the slip of paper that said you'd be dead in 6 months. That was in the very early 90s. And so I've lived through the whole HIV pandemic. And at one point I lived through the HIV pandemic looking like I might be a gay man. I did that very badly, I have to say. And then as a trans person, I was trans woman first of all, and now I see myself as just a trans person. So it's really difficult for me on one level to read this report and then to detach myself from it. So I kind of thought in this bit here, I would just say some of the kind of grand things that bigger themes that I was thinking in my head was that I never imagined that this kind of work would ever be done. I always thought that I'd be out here on my own. And I don't mean that in any kind of big way. I'm still like, you know, it's like I often do these events and I'm the only person that's lived with an STI for all of my life, or for most of my life now. And it's a lonely place. You can't begin to describe to somebody what the intersection of being trans and HIV positive is like. I mean, it's hellish because the stigma that mounts up at that place is enormous, and it's enormous every day. You know, it's like I'm in Spain and I have to have private healthcare, and literally the hoops and the doors that I've avoided opening and the doors I need to keep shut are continual. If I try and date, the doors that I have to keep shut, the doors that I have to open, the blocks. So when I read the report and I read about the blocks that many people face, I can only concur and say to you, I never thought I'd see this kind of work being done. So from that perspective, thank you for a really good starting point. But as somebody that is impacted by these services, this is a starting point. This is a starting point. And in a way, what I want to say, which I suppose kind of almost goes slightly not against what MJ said. I love everything that MJ says. But in a way that, like, I feel like what's lost is often, what's never not talked about on reports is the one person who's diagnosed and they are HIV positive. What happens to them? We've made sure that the waiting room looks nice. We've made sure that the materials are nice. But then they go out into the world as an HIV positive trans person. And that's an incredibly lonely place for which there is no services. I know, I've lived with that. So I'm literally, it makes my heart sing to see that you've done this work. thank you for doing this work, but this is the beginning of the work. This isn't the end of the work. This is merely the beginning. So for somebody that's kind of lived with it, thank you.
No, thank you very much. Yeah, and I think that is the thing that I really take from it as well, a kind of a sense of hope and a potential first step in really transforming what sexual health services, but also, as MJ was saying, like what trans people's sexual lives could look like if we start really being kind of, yeah, thinking really differently about how we can deliver these kinds of things for people and make them about kind of our lives and not what kind of outsiders think our lives should look like. I also wanted to ask you all a little bit about kind of how you felt about, or were you pleased to see the degree to which trans people were kind of involved in the research, in the kind of the methods, collecting the info, designing the research, because obviously that's something that we unfortunately don't see enough of, I would say, very often. And first of all, I'll ask MJ to maybe say a little bit about that, if that's all right.
Absolutely. Yeah, it made my heart sing when I saw that. Yeah, that it's so trans-led and involving trans participants, and a real sense of like, I guess, collaborators in the research, rather than this like expert researcher participant gap, you know, that you often see. It felt more like all the people you were talking to in the survey and the interviews were experts, and I really like that. I feel, again, I think Juno has said something similar. There's something about how research has tended to see like marginalized groups as like almost like in psychology anyway, which is my background, you know, these strange people need to explain themselves to us, you know. That's what research is all about. It's like, why are people trans anyway? What is going on with this? And I just really love to flip it and say, like, trans people are the experts on gender. They're at the cutting edge of gender. What can we learn from trans folks about gender? You know, folks who are doing sexuality different, queer people of all kinds, they're the cutting edge of sexuality. So researchers could be going to them and saying, please share your expertise, or even better, researchers who are in those marginalized communities themselves having a dialogue with the people in their communities about this wealth of experience and expertise that we could be bringing to everybody about gender, about sexuality, about relationships. And I feel like you really get the sense in the report that people were able to say all of the things they need to say, and talk about their lived experiences, even the painful stuff, the stuff that you think probably they would not have said if it was kind of designed by cisgender people, you know, and the questions were asked. I think it just has that feeling to me. Things that really struck me was this kind of idea about pulling out the importance of clinicians talking about body parts and sexual activities, rather than asking people about gender and are you having sex, or who are you having sex with, you know. So a lot of clinicians would, you know, and maybe forms and things in the past would assume that the relevant information is, you know, what's your gender, are you having sex, what gender are you having sex with, or what gender and sexuality of people are you having sex with, maybe how many partners. And in a way, most of those things aren't relevant. You know, it's really about what body parts are you using, what sexual activities are you having. So there was a really nice piece, I think, where somebody who was polyamorous and a sex worker was kind of talking, and it was like, again, you need to find out the detail of kind of what's going on for people, rather than assuming, oh, having multiple partners means maybe you're going to be more at risk, for example, because the research has been done on that and found that actually it's monogamous people are more at risk of STIs because they're more likely to assume their partners are monogamous also, and then that often isn't the case. Whereas those who are in openly non-monogamous relationships, generally speaking, are less at risk of STIs because they're more likely to be having these conversations openly. So it's kind of, you get to that granular detail here, I think, in the report in a really nice way. But yeah, I think that real piece about what should be asked is what body parts and what sexual activities, not that assumption that if you are having sex, that means it must be a particular type of sex, or if you're having sex with a gay man, that means it's this particular type of sex. And so, yeah, I think the clinicians who were asked about what they did in the report, who were really kind of beginning to get it, that's the kind of move that they were making, was to ask quite open questions to people, like around their experience of their gender and how they identify their gender, and also what kind of sex are you having, rather than that assumption that if someone says they're having sex, it means a particular thing. Yeah.
Yeah, no, great. Thanks very much. And does Michelle maybe want to share some thoughts, yeah, around the kind of the inclusion of community members and peer-led research in the report making?
Absolutely. I don't think I would have read it if it hadn't been, because you know, that's what I am about, really, by trans people, for trans people, in a very real way, not in a let's consult this group of people, no, but done by trans people. I get approached almost every day with an email saying, oh, I'm doing this research for my PhD. I think transgendered people are a really interesting group. So I only have to read that, and nowadays I just go delete, right? If it's not involving trans people, either as co-leading or leading, then trans and non-binary people, when I say trans, it's my shorthand saying of all gender diverse people. So for me, as a trans woman who transitioned 50 years ago, the scale around the situation around sexual health is completely different, right? And what Juno said was really important. The stigma around, and I'm not, you know, just affirming your words here, Juno, the stigma around trans people living with HIV is massive. You know, we have a lot of trans people in our services, either delivering our services or accessing clinical services, who are living with HIV but don't want it to be known, don't want anywhere else to be known, because of the fears that Juno clearly said about that stigma is almost in everything, and the blame puts on trans women or trans people. And again, trans masculine people, trans men, non-binary people are left out of the global HIV response. There are trans masculine people living with HIV. There's only one that I know of that speaks open about it publicly. So those kind of stigmas are not just in the cis communities, they're within the trans community as well. So that kind of understanding, I think, I'm not sure if I got that kind of level of understanding from the report. And I think this is a developing, fantastic groundwork done that can be built on. And I think, you know, I read about quite a few, I don't know, I can't remember the percentage, quite a few people had a good experience of accessing the sexual health services. But it kind of, for me, it wasn't enough. It needs to be more. And I think that's what you're setting out to do, really. And so yeah, I think it's most important that trans people are involved in every aspect, leading on it, every aspect of this report and any other kind of report about our communities, really. Was another question there, because I got tracked off in somewhere else, but yeah.
No, you very much answered the question.
Well, just to pick up on something that MJ said, you know, we just put out that we're having a webinar on sex and PrEP and HIV, right? Because quite rightly, sex and trans people doesn't get talked about enough. And I've been talking about sex for 30 odd years. I'm really comfortable talking really about it. And clinicians need to learn to use the language that the client they're with, the patient they're with, the person they're with, that they use. So if somebody talks about having front hole sex, know what that is, have an idea of what it is. But if you're going to ask questions, ask them in a way that doesn't kind of distance the relationship, but forms the relationship with that individual that you're with. Yeah, okay.
Yeah, and we'll definitely make sure to share details of that webinar with everyone in the chat, because yeah, I can imagine that it's going to be a fantastic event that lots of people will be interested in attending as well. And finally, as well, yeah, Juno, if you just want to say sort of a little bit, I'm sure it's to echo many of the thoughts, but around the kind of importance of trans-led research, and that kind of thing.
Actually, it's slightly different things, really. It's just a couple of... So I thought that, one, I couldn't find anything on ethnicity. And again, one of the things, and I will say this because it troubles me, but I look at the screen and I see white faces. And in the first paragraph of your report, and again today on screen, you talked about the 19% of trans people who are more at risk of contracting HIV, but actually that's not strictly true. It's if you're a black or brown trans woman living in a country without an NHS, who is forced into sex work because of discrimination, and forced into violence, and forced into any number of situations, then possibly you are much more than 19% at risk. And so for me, one of the things that I kind of looked around for, I did dig through it, was to find a kind of a recognition of that, because that's really important. You know, that person, those people, they need to be at the table. They need to be at the table, and they need to be at the table more than I need to be at the table now, because when I leave my house, I did an event the other day and I said, when I leave my house as a middle-aged white woman. Doesn't matter how many times I use they, them here, or I say this there, or I write about sex or doing whatever it is. When I leave my house as a middle-aged white woman. Possibly people think I'm middle class, middle-aged, despite my Peckham upbringing. I think it's really important to acknowledge and to honour the 19%. Because those 19%, you know, one of the figures that goes along with that, and it comes from the AVERT statistics, which go way back now to 2015. One of the things that comes along with that 19% is that of that 19%, a disproportionate number die of AIDS because they're not accessing treatment, because actually the structural barriers to trans people to get treatment are so insidious that you cannot even begin to identify them. They're so difficult to identify. I think that what your report did brilliantly was to start to identify them. And one of the key things that came out of your report for me was that actually there's an awful lot of trans people that don't think that sexual health care services apply to them. And I think that has something to do with the way that we become disconnected from our bodies. Because in a way we go to the GIC, they do this thing that apparently is going to make us really sexual, and then we go off into the world and we have this kind of disconnection. And in one way, I think it's one of the things that I kind of felt out of the report was that actually the connection between the GIC and the sexual health needs to be even more embedded. I think I said to MJ a while ago, we met up in a bar in London, and we said, you know, someone needs to be doing sexological work with people that are having surgery to embed them in their bodies and them and their bodies in them. And so that was one of the things, and hopefully you can give me some kind of, there's some kind of response in regards to the ethnicity. Because, you know, black and brown trans women really, you know, they're the ones who are at the, if there's, you know, the French philosopher Simone Weil said that you only deal with equality if you deal with the sharpest end, the thinnest edge of the wedge. And that might be one person. And actually, in the case of black and brown women, it's not even one person. Often their lives have been extinguished. So you're dealing with the trace of one person. So I feel like we have to, you know, I feel like that's something that I really needed to raise, and I hope that no one feels that I've raised that inappropriately. But for me, it's really important because we're all white. Yet 19%, this 19%, and I've looked into it. Honestly, I dug through the figures. They represent black and brown women.
Yeah, no, I mean, thank you very much, in fact, for raising it. I think I can speak, hopefully, for everyone in saying that don't feel it to be inappropriate at all. I think it's a really important and needed to be heard challenge. I don't know, perhaps, if either Ruth or Oliver want to speak a little bit to the levels of racialized people who participated in the research, or...
I'm happy to speak on the panelists that I invited. Ruth, perhaps you could speak a bit more on the research, if that works for you.
Yep. So in terms of both the survey and the focus groups, we, and in retrospect, that was perhaps an error. We tried to collect as little demographic information about people as possible, just, I suppose, to kind of avoid that being a barrier entry point to participation in the research. So I couldn't speak to the specific statistics of people who participated, and that's maybe a learning point for us, because I think it was about trying to find that balance between not asking, basically allowing people to identify as trans and therefore participate and not collecting more information. But maybe we kind of went too far on that balance, because it means we don't have that breakdown of information. I can say that in the groups they were majority but not exclusively white. So that in terms of the focus groups makeup, that's what it was. But I think everything Juno said is absolutely valid, and I think, you know, really something we do all need to consider. It is an all-white panel, and I think that's a fair point to make, and I think the points you made are really useful for us in terms of how we think about what we do next with the research and how we use it. I didn't know that about the kind of breakdown in terms of ethnicity of that 19%, so that's just an interesting learning point, and again something I'll go in and look into more and learn more about. But no, I think, you know, just to echo Vic's points, it's absolutely, I think it's important to raise, and I think it's valid and very valuable.
Can I just say one really tiny thing? It's just that, and it's just to say that I've seen the 19% or the 49 times more likely. I've seen that 1,000 times now, and I've also seen 1,000 times no black and brown trans women in the room. So it's a bit like we're using data on them, but they're not present. And I think that that's a really important, and it's a learning curve. It really is a learning curve, and like, you know, but I'm hoping that, you know, I'm in my mid-50s. For how long I will be going on doing events like this, I don't know. I write now principally, but I mean, I would hope that would be a learning curve, that where people go, actually, well, we can't really use the 19% unless we've really got those people present in the room. So that is just that, and it's not to say that the report is wonderful. I honestly, the report fills me with joy, but then there's a part of me that feels not joyful because of that.
No,
Can I just say something? Sorry, can I just say, I think what Gina said is absolutely bang on, right? And you know, just say it can cure 58% of the people we see are from Black and people of colour. We're based in South London, our clinical service are, but our therapist is all online. However, it's really important, again, like Gina said, we're sitting here all white people, and I'm not sure, perhaps that the takeaway point is to have another session that's much more inclusive. Get feedback on the report from other people that might not feel they've been included or less included. So I think, you know, this is the beginning of something that you're doing. And I think that growth might be a real opportunity to really consider very carefully. And especially as today is Black History Month, you know, but it's Black history. Black people's issues are not just on a month, just like trans people are not. You know, we as trans people have also been excluded, and Black trans people of colour, as Juno very clearly said, are excluded in many sexual health, HIV and wellbeing services.
Yeah, I think there's a place in the report that it does come out, but it's quite hidden. But there's, I was particularly thinking about that point that somebody makes in the report, or a few people make, about the energy that's required to self-advocate. Yes. And how hard it is when you have to go into clinics and you're going to have to explain this stuff about yourself. And I think you get this sense there of, like, the more marginalised you are, the more you're going to have to explain yourself, the more energy it's going to take to self-advocate. And there's one person who talks about being, I think, Black and trans and a sex worker, and you really get that sense from that quote of, like, this is layer upon layer of, like, off-putting to go to services, because you're going to have to explain all of these aspects of who you are, or you're going to be marginalized in all these ways, or have someone respond poorly to you in all these ways. And a similar maybe issue around, you know, this importance of having people you could take with you in terms of support, that came out really nicely in the report. And again, who has access to somebody that you could take along, who could be with you, and who that might be. So I feel like it's in there, but yeah, I completely agree with Juno and Michelle that it needs bringing forward more and having more conversations across diversity when it comes to race and class. Disability is really nicely dealt with, but race and class does not so much of that in depth, like what's the impact of this multiple marginalisation.
Yeah. Can I just say, is there going to be a question about sexual health in gender care services? Or are we responding to that now? Because I have quite a few things to say. But anyway, I'll wait.
I'll maybe come back to that in a little bit at the start of the Q&A, perhaps. I think that we've covered, I think, some of that discussion, and again, I really thank you for bringing that challenge to panelists and kind of to the findings of the research. Again, I think that's something that we're kind of, it's good to hear, and that we will kind of try and take forward and move with constructively. But I think that probably speaks to perhaps the question that I did have around any gaps in the research. Possibly that's your kind of biggest flag up on a gap. So because we have a little bit less than 10 minutes until we're going to take a break before we open up to our Q&A, I wondered if I could perhaps ask each of you if you had a kind of one take-home message that you felt would be important to any clinicians who were attending the webinar today. If there was sort of one thing you'd want to pick up and run with, what might that thing be? And can I ask Juno if they'll answer that question first, please?
I'm sort of dreading you coming to me first of all. I've had 30 years of clinicians treating me. I have to say that I have to just, if I can, I'm going to try and be quick. I'm like everyone else. I'm paid to talk, so I'm like a talker, and I love talking. But I remember the first time I went to Clinic Q with Michelle. I've been serving as a kind of patron first of all, and then a director of Clinic Q for the last few years. And the first time I went to Clinic Q, I walked in and I felt my whole body relax. I felt everything about my body relax. I felt my stress, my anxiety, my sense of what was going to happen. Because for all those years I'd been going to clinic. You have to understand that sexual healthcare in this country was set up for men, principally white gay men. But men, full stop. Because women, if you're a cis woman, you're treated abysmally by these systems as well. There are no, there are very few services for cis women. So when I went to Clinic Q, I relaxed because I realized that the people that were going to see me would understand me, and they wouldn't ask me silly questions. They wouldn't tell me, they wouldn't say to me, did I need to go for a cervical smear? But they might talk to me about my prostate. They wouldn't ask me if I'd had surgery. They wouldn't ask me what kind of sex I had now, or what kind of and it's I have to say that I have still never had that. Because of my connection with Clinic Q, I've never become a patient of Clinic Q, much to my sadness. I wish they'd existed for all the years I've been positive. So I still don't have that, and I still have exactly the same barriers. Because part of the thing is, and one of the things that I would take away from this whole report is that the reason why, to me, the one person is important is because often we are so low in numbers that it is just one person. I think I'm one of the only trans people that goes to my clinic. So therefore, for them to change the whole clinic, you face that thing that you always face, which is where people go, well, it's just one of you. I'll just get your pronouns right. If I get your pronouns right, oh, you're not she anymore. Oh, I've got to learn that now. I think it's really important that if clinicians are listening, it's just about working with kindness and trying to create a comfortable space in which anyone can walk who's having a tough time. Because it's never easy going to a sexual health clinic. If you're going there, it's because you're worried that you might have something, or you're keeping an eye on something, or you do have something. It's not a stress-free time. And I would say, if you're a clinician and you work there, however stressed you are, just try and, because I've experienced it for almost 30 years. So a plea from me is to try and create a comfortable space. And that doesn't mean beanbags and rainbows on the wall. It just means in the way that you address me and deal with me. Find out the right pronoun, even if you have to make a kind of thing and say, well, what's your pronoun? This, whatever it is, find out my pronoun and then get it right. And then listen to me when I'm talking. And I think that that's all trans people. We don't want an exceptionalized framework. We don't want to be othered. What we want is what we're not getting, which is to be treated decently. And we're definitely not getting that. That's what we want. So just treat us as decently as you should be treating everybody. And I'm sure that you will. And I'm sure that you
Would you mind if I responded to Gina?
Yeah, go for it.
I remember that day when we were watching with you today. But and it was lovely to see your face and what happened to you but you see at Clinic here, although Gina mentioned trans people don't necessarily need a special place. Before I set up Clinic here, said, this is what I want to do for about a year, to have a space for trans people. I didn't know what that looked like. And because I'd been involved so long with HIV and sexual health, people said, you can't just have a special service for trans people. They'll never come. They won't come. Well, I'll tell you now, we can't keep them away. But the thing is, what is a waiting space usually, we've always set it up with tea and coffee, come bring sandwiches, bring your friends, bring your dog, bring your guitar. And all people have done all that and sat on the floor, chatted with friends, made friends that they're still friends with from the beginning right through now. And they come for a service. So it's a community space that is essentially a waiting area where people go for a service and go for counselling or go for a sexual health service, or we do cervical screening for people who have a service as well. And so that kind of thing creates a different environment. I didn't want to copy what was already exclusionary space for trans people or felt that way. So I think it's really important to see what the community wants from a service, really, in the local area. And it should never just be central. Anyway, but gender care, can I say it now? The thing is, there's been a mistrust. I'll keep it quick. There's been a mistrust, as we know, in gender care services, that, if you're having fun and sex with the genitals you were given at birth, and you don't want them, then you shouldn't be doing this. And if people get that message, if it's, if clinicians, and I'm not saying all clinicians have that message in gender care services at all, but, the pathologization of trans people gives that kind of message. So there's a fear and concern. So it depends who's delivering the gender care services. If it's trans people delivering it, then it's going to be different. I'll stop.
No, thank you. And MJ, do you just want to give your kind of things for questions?
It follows on nicely, actually, because I feel the same. It was the first time was only a year ago that I went to Clinic T, but a trans-specific clinic, but for an STI check and for a smear. And it was exactly as Gina described, that sense of the body being so much more relaxed in that setting, like just knowing somebody was going to get it. It wasn't just getting the gender stuff. There was a really great and very sad quote around having a smear test in the report about somebody trying to slow it down and saying that they were really scared and being kind of dismissed and told, oh yes, no women like having a smear test, and it was a non-binary person, I think, or a transmasculine person, and yeah, like the evidence is that for those kind of examinations, you can make all the difference by doing it consensually. So, and that's what comes out of the report. The main quote from the report that starts the whole report is about care before, during, and after, all the way through the process. And if you do that with an exam, like a smear, the whole body has a whole very different experience. So not only do clinicians really need to be clued up about gender, but they also need to be clued up about consent and trauma. And if they're working in a trauma-informed way, if they understand embodiment and how trauma works in the body, and if they're working in a consensual way, so at every stage of that smear test or whatever it is, they're checking out, getting consent before they do the next thing, letting the person know in this ongoing way of what it's going to be like, that person have a really different experience. So I suppose what I'd like to see is, in terms of clinician training, that joined up piece of like, we're training clinicians on intersectionality, right, and the gender, sexuality, relationship styles, but also race, class, disability. But we're also training them up on how to operate consensually and in a trauma-informed way. And if you read kind of the more recent literature, people like Gabor Mate, the trauma-informed type approach to medicine, it's so vital. Like, so much of, we treat bodies as these separate parts to be dealt with separately, but actually we need to treat them holistically. We need to understand how the nervous system works if we're going to also be dealing with the endocrine system or the musculoskeletal system or the gastrointestinal, because they're all interconnected. And so in terms of the kind of things, you know, STIs, and in terms of screenings for cancer, it makes sense to also bring in a trauma-informed approach, because the more traumatized people are, the more at risk they are of getting these things and them hitting hard. If you can work in a trauma-informed way and help people and treat people holistically, then you're better off. And in a similar way, I'd like to see joined up the sexual health piece with more of the kind of sexual education piece, because what's also really relevant to whether people get STIs is the kind of sex they're having. And I think most people, not just trans people, most people their starting point for sex is, this is what counts as sex, so I've got to follow this default script, you know, usually of some kind of penetration. And what came out of the early days of HIV was a bunch of people exploring kink, exploring tantra, like trying to find out what other ways of having sex are there that don't start from this script, and that actually might be an awful lot safer for people. And I just don't see enough of that conversation. It was in Juno's book, Queer Sex. You know, that's where that conversation is happening about the diversity of ways of having sex. Is it happening in sexual health clinics? Are clinicians saying, what do you enjoy sexually? You know, what really turns you on? And how can we see about you doing that safely and consensually? Like, that's what I want to see happening, whether that's in extra workshops or whether we're clearing up clinicians about that, or all of it. You know, we're sort of like got the sexual health over here and like sex ed over here and stuff about sex and consent and survivors over here, but it all needs to be joined up in my view.
Great, thank you very much. I'm now going to invite everyone to take an 8-minute break, as we've overrun by 2 minutes, which I think is pretty good going, actually. All of the panelists are going to turn their cameras off, but yeah, if you need to send a very quick email, get a cup of tea, etc., we will see you back here at 3:15 when we will be doing the Q&A. Okay. Okay, so I can see everybody again. So we're all back. I don't know if everybody else is back, but I've just got to go with it anyway. So we've had lots of questions actually, which I think you'll all be able to see in the Q&A box on your screens. We've got, about 45 minutes for the Q&A. I think, unfortunately, we probably therefore won't be able to answer all of the questions, and I'm gonna completely ruthlessly and at my own interest pick the ones that I will ask people to answer. So I thought I would start off with one that Zoe asked, because I noticed, and Ruth mentioned actually, that the participants in the research were overwhelmingly very young. So Zoe asked, congratulations on a great report and important work. Have you come across any data on older trans people, typically transitioning between 1970 and 1996? I asked because anecdotally, it seems to have been usual for reconstructive surgery to remove sexual sensation, and in that sense, fundamentally to compromise sexual health. So I was just interested if people had an answer to that, or broadly some reflections on what we might expect to see or hear or may have missed out on, because so many participants were younger people. Would either Juno or Michelle like to answer that one first?
Shall I go first and then Michelle? Yeah, I did think that was a bit of a shame, because I think that I think that when you're talking to a lot of the time in that age group, you're talking to people who, by pure age and by experience, are seeing themselves as outside of sexual health care. They're seeing it as being something that they might encounter at a certain point, and I think that. I think historically, especially, well, I think for all trans people, historically, we were told that we had to be a certain way and act a certain way, and that we would be, and if we did that very well, then we'd be made to look as real as possible. And I remember saying to my surgeon, hold on a minute, I'm going to talk about orgasms, and meeting a kind of blank wall, really. And in a sense, for 10 years, for 10 years, I was turned away from surgery because I was HIV positive. And I had some terrible experiences of people saying to me things like, you're going to regret the risks you took. You're going to, it's like there's this kind of loading of, so I think it would have been really interesting, but actually there is no data. This is why the data that you've done is so epic, because there is no data on us. What you have is our spoken word, and in a way, I suppose that's what I've tried to do in the books that I've written. And this isn't a book. What I've tried to do is to collect as many voices from this age to that age, in a sense, to try and give a kind of sense of us now, and what we're doing, and how we're having sex, and with whom, and where, and how often, that kind of stuff. And I think to a certain extent, that might be the next stage is okay, how do we get people who are already really engaged with sexual healthcare services, who don't see it as being disconnected from them? And if we're still not getting that, then there must be an issue. There's something going on. And I suspect that what's going on is that the people that historically delivered the care to us, especially as trans femmes, trans women, trans, however you see yourself, it was delivered through a misogynistic lens. It was delivered through sexism, in the sense of, I'm going to make you a real woman, and you're going to go off and you're going to open your legs, and I'm going to tell you your depth, and you're going to, it was delivered through that lens. And actually that's changing hugely now. I mean, the world of us now is so vast. That's why I use the word trans, because it's so vast now. We are a sea of people. A grand, wonderful, petulant, fun, emotional sea of people. And I think that to a certain extent, you maybe won't capture our voices, but I think that what you've done is you've started to go back to these people in 10 years' time. Track these people and go back to them in 10 years' time. And then in 20 years' time, begin to build up a real coherent picture of us.
Yeah, absolutely. Was a question about older trans people, and okay, well, as someone who's 71 and transitioned 50 years ago, I think I can speak from that place. However, we do see a lot of people in our services who are trans, who are having very active sex, and they're older trans people. So obviously clearly not everyone, but some trans women have come to us and never had a physical examination of post-surgery, which they had 45 years ago, but they're having active sex and had lack of awareness about HIV, HIV prevention and all this, because it wasn't targeted, not focused on trans people. So, you know, she's just been living what we would say now as stealth, but as Juno pointed out, when you transition then, you're supposed to just disappear and, you know, into the womanhood that you become suddenly without looking at our, you know, and identities in a more wider sense. So there's no research for that age group about sexual health, sexual satisfaction. And I recently put out on social media my growing interest, not just because I've got a vested interest as an older person, is older trans people actually are sometimes excluded from all services because there's not that research, there's not that focus, there's not that information about trans people, nor targeted at trans people. And perhaps, you know, we could do a bit of work on that. But I don't know. But anyway, I think, yeah, I lost my train of thought. I do that because I'm 71.
Can I just come back in really, really quick, just on like a really quick thing? I think that I remember when I first of all started to write Queer Sex, and I approached people, and because I was known as someone that was HIV, everyone, you know, my HIV is out there. A lot of trans women that I approached were really quite hostile to talking to me.
Yeah.
And when I asked them why, they said, well, isn't it bad enough that we're having to live with being transness? If we talk to you, people are going to think that we're HIV.
Yeah.
And it was this thing, because actually I don't know, you'd have to go to the ends of the earth to understand what it's like. That's why I say when I talk about Black trans women living with HIV,
yeah,
you know, to understand that intersection, you'd have to go to the ends of you'd have to run to the ends of the earth with bare feet across broken glass to understand how tough that is. And I think that that's probably why there is nothing, because at a certain point 20, 30 years ago, it was so tough being trans. All you could do was just get your head down, hunker down and survive.
Just say, yeah, and I'm a director at IOGT, which is an international group of trans women. We also include trans men more recently, with the global response to HIV. And Gina's absolutely right. In some countries, trans people of colour and trans people who are living with HIV are sometimes not able to access HIV medication through many different reasons, but mostly because they're trans. So, yeah, anyway. We're going to talk about PrEP at all. Anyway, go on.
We will do at some
point.
There are two quite similar questions that I'll kind of group. So there's one from an anonymous attendee that is, how do we bridge the gap between having services for sexual health and services for sexual health and well-being? Alongside one that asked, interested in how we create a culture amongst sexual health providers to discuss sexual pleasure as an important part of trans sexual well-being. And I wondered if you wanted to start us off kind of answering to those, MJ, because that's obviously what you were kind of finishing up talking about before the break.
Absolutely. Kind of disturbed I didn't get asked the age question, as I'm edging up on 50, but apparently I'm seen as a young'un or something. I feel pretty old anyway. But yeah, like this is really important. You know, I just feel like it needs to be joined up. So we need to be talking about sexual pleasure. As Juno was saying, and I've heard them say it a number of times, this point about in gender services, that there is nothing about sexual pleasure. There's no sense of like, you know, that there's an idea of genital surgeries a lot of the time being all about looking a certain way and nothing about how it's going to feel, and that should actually be central as a question, at least for people where that's really important. So yeah, I feel that we do need that joining up, and that's what I would like to see a lot more training on, is really getting people thinking critically about sex, because I feel like sex advice, sexual health services and sex education are still coming from this starting point of like, we assume sex is penis and vagina sex, or at least some kind of penetration, and we're all about how do we stop people getting STIs. And it's missing out so much of what's vital. You know, what should really be at the heart is pleasure and consent. It's like, how do we know that the rates of, you know, sexual non-consent are alarmingly high. They're particularly high for trans people, for LGBT people, and for trans people. So why are we not joining this up? Why are we not helping people to figure out what they really want to do sexually, or what they don't want to do, and how to articulate that to others? That seems to me the most important piece. And people are so embarrassed about talking about sex. Like, one of the big reasons why people get STIs and have non-consensual sex is because of the massive blocks around communicating openly about sex, even with people you're having sex with. So clinicians need to be able to communicate about sex in a much more holistic way, and encourage the people that they're talking with, you know, how to tune into what they want sexually and articulate that to others, and really know their limits and boundaries and articulate that to others. Those are pivotal, and they're just not happening hardly at all, I think. So yeah, I think that what people are alluding to in the questions, if we need to join up health and well-being, we need to have pleasure at the heart of it as well as consent, like that. But it's much bigger, right? Again, it's like, what can we get from this report that's on trans people? It's actually helpful to everyone, because I'd like to see that in sexual health across the board, not just sexual health aimed at trans people or LGBT people. It needs to be out there everywhere.
Can I say something? Absolutely spot on, bang on right. And just talking about bang, a lot of people are so used to having a quick bang somewhere, and then they might go to a sexual health service. So, you know, might have it public sex or anything. And we did, we used to, before COVID, used to deliver sexual health, HIV prevention, PrEP, talk about PrEP and deliver it in the sex on premises for trans people. Now, some of those trans people, and that's what I'm calling them, didn't necessarily see themselves as trans. They were people who went there dressed, or what you might call cross-dress, for sex with cis men usually. But they would say to us, you're giving us these leaflets, but it's only talking about trans people. It's not talking about me. So we changed the leaflet. You know, you can't, if you don't fit in with us, maybe we'll change it and let's see what works for you. So, and just to say, I've been involved in sexual health, as you know, for so long. You know, working in clinics, they usually have a time limit for each client, each patient, as they usually say. So in defense of those, there's often not that time to look at more. Clinic as a sexual health and holistic wellbeing, we make time for people. Our greeters are trans. That's the first person you meet, and that's the first person that sits with you as long as need be in the session until they go on to something else. So, you know, I think, you know, there are a lot of people who deliver sexual health services who are kink, who are, you know, enjoy sex in a different way than just penetrative sex. So there are clinics that do that and have that awareness. But yes, I think it's few and not the many, really. And also the way sexual health services are set up, they just don't have the time. And that needs a rethink completely.
And I just, I mean, this is really quick, Vic, because I know we're short of time, but I mean, I think as well, I think the reality is that we have to understand, like most structures that exist in our world, these structures were set up by men, for men, about men. And, you know, it's like, I remember going to a reveal a couple of years ago, about 3 or 4 years ago. I went to a reveal of the new HIV stats in the UK that showed a huge drop in the number of young, gay, white men between the ages of 18 and 25 who were becoming HIV positive. And there was a massive drop. But all the other lines were static. So I remember, I think you were in the meeting, Michelle. I put my hand up and said, sorry, I think I'm in the wrong room. Where's the room for the other lines? Because I think I'm in the wrong room. This is just a room about white men and young gay white men. And young white men have always been at the front of the queues. And So in some senses, it's really important to see that, so when I used to go to Chelsea and Westminster, for example, 10 years ago, there would be endless notice boards about groups that were set up for gay white men to talk about sex, to talk about pleasure, to talk about intimacy, massage. It's just that there's a lot of work to be done, and it's not going to get done by them for us. It's going to get done by us for us. That's how it's going to happen. And I think that's really important to take on board.
Absolutely, we were there together in that meeting, and for many years, for most of the time, there was no data on trans people living with HIV in the UK, none at all. For over 30 years, none at all. And it's mainly, and I will say it was mainly because of Clinic Q's campaign and talking to people at PHE about how we can change this, that we got other people in other organisations involved to look at that change. And now we have the data that we can build on, and that's really, really important. And I'm not surprised that it's by men for men, because before HIV, before AIDS in the early 80s, there was no specific services for gay men, none at all. And I remember time, when people probably didn't attend a service because you get in prison for having sex with somebody that was, cis man. So it's, and that kind of locked in response by the LGBT community at that time, less trans, was mainly focused on cis men having sex and how to set up services directed at them. Now you can't shake a stick without seeing a sexual service for cis men, but you have to throw a few sticks, like at Brighton at Clinic Q. There's Clinic Trans in Birmingham, which we mustn't forget and doesn't get mentioned.
Just really quickly, can I just say that I completely agree with Michelle. And I was there I was diagnosed in 1991 when these services were beginning to, and I always say to people, this isn't about demonizing that gay men had all of that stuff. This is about saying we actually can learn from them, because everything they got in adversity. No one wanted to give them any money. I remember being positive and reading the Sun's headline that said, ship them off to an island and shoot them. That's what, and against that backdrop, gay men, principally gay men, but not just gay men, but gay men got together and they organised. And in a way, that's what we've got to do as trans folk now. So rather than imagining that anyone's going to paint the walls for us, we've got to realise that we've got to paint the walls, and we've got to also realise that we need to build the walls. And that only when we take control of sexual health care services in connection with gender services, and as MJ says, bring sex into the mix. Only when we say, no, hold on a minute, don't make me look real. I want to know about my orgasms, thank you.
Yes.
My genitals can look anyway. Let's just make my genitals look. I mean, I think that, it's like we can learn from them. I always say that this isn't about saying gay men went through a horrendous time.
Horrendous.
That was off the back of being, being illegal to be gay.
Yeah.
So off the back of that, AIDS came in, late 70s, early 80s, and just decimated. But they got together and they campaigned and they organised and they created structures, body positive, ACT UP, the list goes on and on. They rubbed feet, they built buildings, they got beds, they changed services. We need to do that, and actually,
I think
Michelle
we are.
Says,
so go on.
One more thing, and then I'm going to stop because I know that other people need to come in. When Michelle says the PhD that started to collect trans data on trans people, it was because of Michelle and Clinic Q. Had that not happened, that wouldn't have happened. They weren't even collecting data on us, and somewhere in history it will be written down that Michelle Ross set up Clinic Q and then made this stuff happen. Somewhere in history that will be written down. No, I'm going to say, you know what this is like between
I know.
So it's like in one way, this is, it's like we have to recognise what Clinic Q have done as to ripple off around the country and creating other stuff. But this is the way we're going to improve stuff. With MJ in there delivering services.
Yeah. Can I just say, to come back to what you're talking, we are building the foundation, and this report really builds on those foundations. So I really want to acknowledge that, and thank you, Juno, for what you said. You know, I often dismiss it, but absolutely, this report builds on what we've ever done and takes it further. Fantastic.
But I thought that maybe leads a bit nicely onto, though, a couple of questions around essentially how did Clinic Q happen and how do we make it happen in Scotland? I appreciate that's probably something that we could do an entire webinar on, but if you sort of could give us the really quick lowdown, then that would be great. Yeah.
Okay, in 2 minutes, I'll try and do it. Well, very quickly, you know, being involved in sexual health, I knew we were seeing HIV mainly at THC for 26 years, the 10 Seconds Trust in London. I knew we were seeing, and I was a psychotherapist, mainly working with cis gay bi men around HIV, and I knew we were seeing trans people, but trying to refer trans people to a service, it was like block, block, block. No, we can't see them because they've not had surgery. We can't see them because they have had surgery. We can't see, they don't fit in. So I knew that at that point, I set up in-house training in THC, which were wonderful and really helped me develop that around trans stuff and HIV and sexual health. And then I knew that I wanted a space, some kind of space trans people could come, chat, have a service, something that we could build on. And so that's how it started, really. That's how Clinic Q came about. And I trained loads of clinicians over 3 days to deliver the service with us, not for us, but with us. And that is the most important part. Clinic Q is about our power as trans people. And we partner with King's College Hospital, and we're commissioned by 3 boroughs. It's only a small amount, but we're 3 boroughs in South London, and who are committed to what we do. And that's really important. So, you know, it's about what we can do. And if we did it, I know that everybody else can do it. You know, and we celebrate Clinic T in Brighton and the Birmingham service as well. So I know you're going to do it. You're what you've done, you know. And but we are holistic. We are very much holistic. We have a huge counselling service. Our waiting list is going up, but we still have it. About to take on more counsellors. So it's really important, like Meg John was saying, to be holistic. You know, we have 2 booklets out there that talk very directly about sex and trans bodies, our identities. Is that 2 minutes? Did you get a sense of how it came about, or do you want me to say more?
No, I think that was a really good overview. Part of the questions that someone asked though is that are all of the staff members at Clinic Q trans?
No. And in a way, neither should they be, but most are. And most of the people who direct the service are directors or deliver the services, manage the services, are trans and non-binary. And, you know, but we, as I said earlier in my introduction, that we are inclusive. Let me say that again. We are inclusive of cis people who self-identify in that way within our service. But, you know, some of them have been involved either with our service for so long time, or they're very involved with trans people or partners of trans people. So, you know, no, but most are.
Great. I want to talk a little bit, or I mean, I don't want to talk about, I want to ask the question about PrEP. So Ivanka said that they were interested to see the issues around accessing PrEP highlighted. I wondered if either Ruth or Oliver actually wanted to speak a little bit too. They asked about what ideas, thoughts or suggestions were put forward around resolving it, and like what exactly was it that people were highlighting in terms of the issues with accessing PrEP? Was it around language? Was it around people not having the information? Like, could you tell us a little bit more about what you found out about PrEP and trans people, basically?
I'm happy to speak a bit about that. Mainly, Scottish PrEP guidelines don't include non-binary people at all. Like, genuinely, it's very binary gendered in the guidelines. And one of the things we also discussed, I think, was around people self-selecting and actually looking at the guidelines when kind of doing some kind of background, because of this whole thing around trans people feeling that they have to do work before even getting to a clinic, and this emotional labour, like being prepared and well versed. Like they'll look at whatever guidelines say, like maybe like, can I access? Oh, it doesn't have me in this pathway, so I guess I won't even go to ask about PrEP. One interesting thing was from the survey, we had some specific questions around PrEP, and some people were eligible for PrEP and indicated that they didn't know they were, and that they might go and investigate that further as a result of even taking the survey. And a lot of the PrEP media is also binary gendered and doesn't include trans men in the language. So trans people then also don't see themselves represented in it and don't think about it as an option. I'm just looking at the rest of the question. I think, yeah, so a lack of knowledge and information available in a language and like it directed media that's directed at trans people, including non-binary people specifically. And it's not that people aren't at risk, people are at risk. Through this survey, we found people were definitely eligible and in the right group. So like having unprotected sex and having several unprotected sex events in like past 3 months and stuff, like guidelines kind of spell it out. But yeah, so there's work to be done with PrEP for sure, and initially changing the guidelines, just start with that.
I think I can just add to that, just to say, and I suppose Oliver's already kind of covered this, but even if it's not changing the guidelines, it's almost adding to them. So if there could be specific guidance around, in very explicit anatomical terms, rather than I suppose using gender and sexual orientation as almost code for types of sex, and making the assumption if you're this gender and you're this sexual orientation, that means you'll be having penetrative anal sex or penetrative vaginal sex. And instead, if that's what the risk factor is, just lay that out quite explicitly. I mean, I think with PrEP, one of the things we found was that for folk that reported that they were eligible but hadn't accessed it, the other barriers came into play there. So it was things like people were frightened of attending the clinic, or were frightened of how they'd be treated because they were trans. So I think you've got the general barriers that affect access to sexual health services coming in there, but then there is something specific about PrEP. And the criteria as it exists does explicitly mention trans women and trans men, but I think it's just about drilling that more specifically into body parts and types of sex, just so that people can really glance at it and understand if what they're doing means that they would be eligible. So I think that's one of the pretty easy things that could be done within services and within the national PrEP stakeholder group is to develop some guidance of that type for folk, and I think that would be to the benefit of anyone trying to access PrEP, and not just trans people.
And did any of our other panelists want to share some thoughts generally about trans people's access to PrEP? I know, Michelle, you'd wanted to say something about that.
Yes, I do. And I've had reports, I've been on the England PrEP trial on the advisory board about making sure it's inclusive and available for trans and non-binary people and in England. And that comes to the end now, isn't it? And the commissioning of PrEP is going to be rolled out in England. However, still I hear from trans people that they went to a service and they were told they weren't eligible for PrEP. So a trans non-binary person who was having front hole sex was seen and treated as a cis woman, they're not at risk. They didn't take into account any atrophy, maybe on T, on all the issues that can be present. And the latest findings that we're going to present on the 22nd of October really gives a very clear insight into the issues. But and that's what clinicians need to take away and learn, that not to treat people in that situation as if they're cis, right? And that it's really important. So PrEP for me is such an important thing. There's no interaction, negative interaction with hormones. You know, PrEP works. In all the results that you're going to hear about is that, you know, there's good levels of PrEP in all. There are certain issues that you'll find about, and also event-based is not recommended for trans people who are either on hormones or have had surgery, because event-based doesn't offer the necessary protection level, so it's a daily base of PrEP. I'll stop. Juno wants to say something.
Can I just say, just really quickly, I think it's this is one of those areas whereby there are huge alliances to be made, because, you know, one of my other hats on is I'm a trustee of the Sophia Forum, which is an organisation that advocates for the rights of women living with HIV and women at risk from HIV. And, you know, when we've interviewed women, almost exclusively, women have said that they don't think PrEP is something that's aimed at them or that is about them. And I've always said to, you know, when people have kind of talked about advertising for PrEP, and I've always said, no, you really want to be targeting Freshers Week and 18 to 30 holidays, because that's where people go of both genders or any gender, and they go and they let their guard down. And actually, there are an awful lot of young girls that would go on those holidays, or young women that go on those holidays, and they let their guard down. And that's where you need to be targeting. But, you know, it's like it really is like head against the wall, really, stuff. So I think that what we need to do is to form alliances, go out with and look and join up with women's organisations who are trying to do exactly the same thing. And it really is that thing that, you know, the campaigns are targeted at a very slim group. And I understand historically why that's the case. And part of it's to do with the fact that the structures that were in place, I've just literally written a paper, and the structures that were in place to deliver HIV care were developed 30 years ago. And sadly, a lot of the structures are still the same, and they need to change. We need new structures now. The structures are not fit for purpose anymore. We need new people, we need new structures, we need new CEOs. And that's not me being horrible to CEOs. We need new people that are going to go, you know what, that campaign's not going to appeal to a 20-year-old woman who's just gone off on a 2-week holiday. But we need to be getting to them, because 25% of all cases in England last year were women.
And can I just say, absolutely, Juno, and just to say that it's known that many cis women do not use sexual health services in the way that cis men do. Absolutely. And that community-based delivery, local delivery to access to services, GP delivery in PrEP, I mean, you know, GPs or local community services, you know, take the stigma out of taking PrEP within your community. You know, many Black and people of colour communities actually are not, well, they are, I know the Sophia Forum focuses on Black and people of colour, women of colour. But, you know, generally the main campaigns do not focus on access in the local area, because, you know, so it can be many different reasons people don't use centralised sexual health services.
Great, thank you. And I'll now pivot slightly to a question from someone who says that they work in a gender clinic and SRH, I am guessing sexual and reproductive health setting. And they ask, I'd like to know what educational tools I can access in order to ask the right questions in the right way when speaking with my trans patients. I think sort of the million-dollar question to an extent, and it might be that it's about focus stuff for sexual health practitioners, but also, I guess, do people have recommendations generally about kind of 101 online resources, things of their own they'd like to plug that they think do a really good job? I was going to ask MJ if they maybe wanted to start by saying if they had any suggestions, stuff that they thought would be good for people to look at.
Yeah, I'm just trying to think, actually. I don't know if Juno or Michelle wants to leap in while I'm still thinking, or I'm happy to do so. I mean, obviously Juno's book, Queer Sex, is an excellent resource about sex and trans people.
I was going to say, literally, I think read the work that's being done at the moment by trans authors, not just mine. I do think that, you know, mine is some of the only books where I've really kind of like, I've just got taken down what people are doing and how they're doing it. And that gives somebody a really broad understanding of us and our community.
Yeah.
And, you know, I interviewed as many trans men or transmasculine or non-binary people. It's the broadest range of age, you know, from the youngest to the oldest. And I think doing that, and you know, apart from that one-on-one stuff is just Google.
It is. Also, we have lots of resources that we can send to you for you to share if you want, either on our website, or we have training packages that you're happy to share with you that will inform clinicians about services. And if you want, we've trained lots and lots across the countries. I think we even came up to Edinburgh once.
I mean,
anyway.
With my work on this, I suppose what we've tried to do, so Justin and I wrote a book called Enjoy Sex, How, When and If You Want To, and we also do quite a lot on our podcast around this, and I suppose we kind of veered away actually from doing trans-specific, and the same really with my workshop, because it feels like really what you want to do in order to have good sex is pretty much what you'd want to do to have good sex with a trans person or good sex with a disabled person, which is to treat the person and the body in front of you every time you have sex as a new person, a new body that you don't know how it works. So, you know, you could get into all of this about, oh, well, you know, sex for trans people or sex with trans people, here's this specific stuff you should know. But you should never make assumptions about how any genitals work, for example, or that people would want to use their genitals, or what is the goal of sex for you, or what does sex mean for you. So with most of my resources, it's trying to open that up for everybody to, you know, instead of starting with this like default sexual script of like, this is what sex is, and maybe we tweak it a bit, throw out that sexual script. Start with, what do you enjoy sexually, if anything, because lots of people really don't want to be having sex, and we also need to include that and like let it be okay to not have sex. If you do want to have some kind of sex, you know, let's expand this whole menu of things that you could be doing alone, with one other person, with multiple other people, have all of that in there. And then the question of, well, how do you go about doing that in a healthy enough way, in a consensual way? So yeah, hopefully those resources, the Meg, John and Justin podcast that we do, and the book Enjoy Sex, and some of the zines on the Meg, John and Justin website would be helpful. But the reason we don't get really specific about trans people in particular is because we do feel like the same questions you should be asking if you were going to have sex with a trans person, or if you're a trans person wanting to have sex, would be exactly the same as it should be for everybody.
Thank you. Can I just say something? First, jump in like that, MJ. So, you know, some trans people who might have had lower surgery might not experiment enough with self-pleasure. Right? I once said to Juno, buy a dildo, right? And because dilation, as long as you're fully healed and everything's fine, you know, dilation's a time also to have a bit of fun.
Yeah.
So you can use a vibrator as long as everything's fully healed to have self-pleasure at the same time as watching telly and doing a bit of good job on your new genitals for trans women that I'm talking about.
It's so important. It's like totally divorced from pleasure, isn't it?
Absolutely.
So it's assumed you'd be doing this thing to your body that's this chore, but you
Absolutely.
could be doing it in a pleasurable way. And I just think, yeah, solo sex and self-pleasure gets left out of this conversation almost totally. It's just really safe form of sex, great during a pandemic, you know, like let's talk about that a bit more.
I'm all for self-pleasure, believe me. And I think it's really healthy as well, because like, as you mentioned earlier, MJ, it's, you know, about holistic, the well-being, mental health, physical health, sexual pleasure. For people that don't want that kind of pleasure, fine. But for people that do, and knowing your body, knowing that, I'm being very careful here, so don't use a vibrator a week after you've had lower surgery for trans women. You know, hang on a bit, you know, and then increase the side as you go along if you want. But it's really important to be able to know your body.
I almost jumped in on you then. My apologies. All I was going to say was really simply, so, you know, for the last, I don't know, the last 100 years, we've been seen as broken bodies that need repairing by a society that doesn't really want to repair them, wishes that we just go away. And that's the history, and that's the legacy of the history that we deal with. And that's meant that we've become fractured. We've embodied some of that fracturing. We've embodied some of that disembodiment. We know, and in a sense, we've got to be kind to ourselves and kind to the trans community and kind to them, and recognise that actually we've ingested lots of that. And in order for us to get to a place whereby we see our bodies as being beautiful and sexual and smart and enough, we're still, people always just say to me, even now people say to me, oh, so did you feel like you were born in the wrong body? It just feels like this statement from 1880. It's like, I love this body. This body is like a fantastic, the genitals didn't quite work, but it's like it's that, but we have been sold that thing that we're broken and that we will be messy, and that, so, don't see us as being other, don't other us, getting back to the person that wanted resources, just don't other us. Don't see that we need a separate. I really like what MJ said in terms of the work that they do, which is, we just want good sex, and we just want good sexual healthcare.
And also, a lot of these things apply actually across cis and trans. So we get so trans specific. But if you think about that example, like a lot of women who struggle with penetration, a lot of cis women are given, increasing size dilators to use in psychosexual therapy, just as a lot of trans women are given that as well, without any questions around, is penetration something that's wanted? What other alternatives might there be? Could that be done in a pleasurable way rather than a really unpleasant way, or just a kind of mundane way? It's just, I think it can be also useful to think across trans and cis, because some of the ways we're navigating this territory is the same across trans and cis people, or trans and cis women, or trans and cis men, and non-binary people. And it's like, actually, the way that's being dealt with across the board, I think, is problematic, and bringing in that question of sexual pleasure and expanding the idea of what counts as sex would be helpful for all those people. It's not just a trans women specific issue, that one.
As Travis Alabanza says, it's not our trans isn't our problem. Gender's everybody's problem.
Exactly.
And actually, if we were all just labelled ourselves as being trans, we'd all be a damn sight better off, because cis is really a problem. It doesn't work for anyone. I
want to see gender services for cis people. So many problems that cis people have with their mental and physical health is to do with their gender. We know that, cisgender men don't go to the doctor enough. We know that cis women's problems are hugely related to their gender. So why do we only have gender services for trans people?
I could honestly listen to all of you talk about this for days, but I am going to be the big bad chair who wraps up, because we are at 1 minute to 4. And so I'm sure that lots of people are not able to stay any later than that. And so I'm really sorry to anybody who asked questions that we didn't get to. But hopefully you've all found this really interesting and enjoyable. I know that I found it totally wonderful. I've had a really great afternoon listening to you all sharing such amazing things. And as I said, so excited about the report as a real starting point for what might be a new, different way of doing trans people's sexual health in Scotland. I did notice at the very end, someone asked a question around resources and links. I'm sure that that's something that we'll be able to put together and send out to people who attended.
I can just say on that, after the event, we'll email the final report to everybody who attended, and then at that point, I'll find a way to ask permission to retain email addresses to share resources, because I don't think we have permission at this point. So I'll put out a wee SurveyMonkey with some evaluation questions, and also ask about resources and hanging on to people's email addresses to do that. So that will be coming.
Yeah, well, I just want to say a massive thank you to all of our guest speakers, to Oliver and Ruth for presenting the research findings, and of course as well, if anyone who is attending was a participant in the research, thank you so much for taking part in the research, and I hope that everybody who's here has enjoyed the event, and please do get in touch with us if there's any conversations you would like to keep having outside of this space.
Thank you for bringing this. Thank you that you did.
Thank you.
Thanks, everyone.
Oh, there's a poll. What's that?
Oh, we're not allowed to vote, apparently.
Yeah.
I was just going to, excellent, it wouldn't take
it.
Sorry about that.
We're not allowed to do it.
It's just for the attendees.
Are we
still recording?
We stopped filming now?
Oh yeah, we can't.
It's still recording.
We're still recording. I'm not sure if we can move into just.
Should we just